Chrissy, would you please call the roll?
Calling the roll, Mr. Jones,
Here.
Ms. Conwell,
Here.
Ms. Brown,
Here.
Mr. Schron,
Here.
Mr. Miller. Here. We have a quorum.
Chrissy, has anyone signed in for public comment?
No, Mr. Chair, no one has signed in.
All right. Can I have a motion to approve our minutes from the February 17th meeting?
I so move. Second.
Moved by Councilman Miller, seconded by Councilwoman Brown. All in favor say aye. Aye. The minutes are approved. There are no matters referred to committee at this time, and today we have a presentation from our drug court. I'll say this: what I've tried to do as chairman, when I was chairman of Public Works, it was a big world, but the Health and Human Services equally as large, but there were so many different interests and important parts of this of the human services world that I started getting inundated with calls for me to come out and tour and to learn about so many different things. So part of our strategy has been to have an opportunity to present here in the Health and Human Services Committee so that all of the committee can learn. I certainly will tour and visit, but a strategic way of getting as many people in the human services world exposure to expose what they're doing to this council and to this committee. So this is just one more in a long line of presentations we hope for this committee to hear. So we're really happy and excited to have the drug court here today. So we ask that you come forward and present.
Thank you, Vice President Jones, and thank you, other members of County Council, for having me here today. My name is David Mattia. I am a common pleas judge. I'm in my 18th year serving Cuyahoga County in common pleas court, and I'm in my 7th year as running our felony drug court. I'm lucky to have a partner judge now. We have 2 dockets in common pleas court that run drug court. Judge Joan Sinneberg is my partner judge. She is doing her drug court business right now. They have their team meeting followed by drug court. I hope today's presentation will be illuminating for you. Dependency, mental illness, these are broad societal issues, and they take up most of our time in the criminal justice system. Most of the people entering the justice system are there because of untreated mental illness or drug dependency diagnoses. I always joke if we didn't have drugs, my handicap would be a lot lower. I hope to be very informal today. I welcome any interruptions, any questions. I brought handouts. I have a little PowerPoint. I don't want to bore you to death with that, but it's something I typically just use as a reminder to cover topics. I'm going to explain, how drug court works, what's the magic, our success. We have some studies that show that this program is a recidivism busting court. We're going to talk about how we ended up in this heroin opiate addiction mess and how really extensive it is. And maybe that's a good place to start. We hear now about heroin nightly on the news, or you might have some connection personally who's somebody's lost a family member to either just the dependency or their life. It is the overdose deaths are the leading cause of accidental deaths in society now, certainly in Ohio. When I've given you some handouts. Let's look at some of this stuff. There's, I'm a big statistics guy, and you have, right behind this page, there's a packet from 2010. 2010, we were losing 4 people a day to overdose in the state. So it's 1 o'clock, 2 people had already died by today in 2010. The overdose death rates now due to accidental overdose are up to about 6 a day, 2,400 per year. We are most fortunate in Cuyahoga County. Our medical examiner's office has been a wonderful partner in gathering statistics and collaborating with other people. I was lucky enough to serve with medical examiner Gilson on his poison death review committee Learned a lot there about, doctor shopping, overdose. But also, I brought to you today his packet, medical examiners, heroin, fentanyl-related deaths in Cuyahoga County. Inside the first page lists the various types of overdose deaths in this county. I told you there's 6 people die a day in the state. Last year, according to these numbers, we had 183 heroin overdose deaths. The red line on that graph is significant to me and perplexing at the same time. When I volunteered, and when Nancy McDonald was foolish enough to appoint me to be the first drug court judge, I thought I'd be dealing with crack cocaine and powder cocaine dependent individuals. And drug court is now probably the most Caucasian part of common police court. You see this red line, and these are the cocaine overdose deaths. 127 back in 2006, 109 last year. Those numbers have remained constant over the last 10 years. What hasn't remained constant are the arrests for cocaine or crack cocaine possession. We don't see those cases in common police court anymore. There was a change in policy that the Cleveland Police Department adopted several years ago that's probably responsible for the vast decrease in those cases. We used to have what were called crack pipe cases. You'd get arrested, you'd have possession of a crack pipe. And the possession aspect of it was the minute residue of smoked crack cocaine on that pipe formed the basis of the indictment. Most of those cases eventually pled down to misdemeanors, and they were bringing people into the criminal justice system in an unjust and unfair manner. Policy changed, and I'm not here to argue whether it was good or bad, but the consequences are those cases aren't coming to us, so we're not getting those folks into drug court anymore. The uncomfortable fact I get confronted with is, why is drug court so white? This coroner statistics show that 85% of the deaths from overdose are Caucasian in Cuyahoga County. Why is heroin use such a Caucasian disease? I think it goes back to medical parity, basically, and remind me to come back to that. But before I go to that, I want to tell you about, why are we losing plane loads of people in this county every year to heroin overdose? Some of you might have heard of the Joint Commission. The Joint Commission deals with healthcare. Joint Commission determines what's going to be a vital sign. In 1994, the Joint Commission decided that pain needs to be the 5th vital sign. Prior to that, pain was undertreated in this country. It was basically ignored. So in 1994, pain became a vital sign. Doctors asked patients, how's your pain? And shortly thereafter, Purdue Frederick, also known as Purdue Pharmaceuticals, brought a drug called OxyContin on the scene. The Federal Food and Drug Administration, I would argue, failed the public in screening that for its negative effects. Purdue Frederick underplayed or really deceived the medical profession and the FDA on the addictive qualities of that drug. And this is all well documented. Purdue Frederick went on to pay a $600 million fine. Of course, they made $614 million that year on the drug. But OxyContin then was marketed for off-label purposes. It got into the commerce of the medical profession in America. People became dependent. I've given you a story about a lawyer in Columbus who had surgery and developed a dependency shortly thereafter to illustrate this point. But you take pills, Percocet, OxyContin, Vicodin, whatever, they're highly addictive. There's literature out there that shows, up to 35% of those who treat regularly for pain using these medications develop a dependency. 35%. I mean, I don't know why the medical profession uses this as a tool in cases other than end-of-life cancer cases or immediately thereafter significant surgery, because there's medical literature that shows their effect, their benefit is just not there. So back to Caucasian Drug Court. What do you have to get a prescription? Insurance. We know in this country, Caucasian America is more insured than African American America. So the disease took hold more so in white suburban America than it has in the inner city. So let me tell you a little bit about what drug court is. Drug court is a specialized docket. And what does that mean? We basically, how do we get the PowerPoint working? There we go. So you have monitors. So we have extra resources, and I'm here to thank you for those extra resources. The county funds the Adams Board, and the Adams Board funds a contract with our treatment provider for treatment. I'd also like to thank those of you on county council who were responsible for staving off the proposed 18% cut to the Adams Board budget. Frankly, I would like to go on record to say that the proposed cut was unconscionable in a time of economic expansion in the midst of one of the greatest public health crises that our state and county has faced. If you could turn to the packet from the coroner's office, go to the back page. Let's give you a very visual idea of how bad things are. Turn right inside that, Vice President Jones. Okay. Persons in Cuyahoga County annually misusing or abusing opiate prescriptions. Enough people to fill First Energy Field. Persons in Cuyahoga County who annually switch to heroin. Enough to fill the queue. There's 20,000 people there. We have a problem. Now, these numbers are generated by extrapolating back using a factor based upon the overdose death rate. Hugh Shannon of the Medical Examiner's Office has put this together. This was presented to us in the U.S. Attorney's Opiate Committee. And these are numbers that we're familiar with, but they really bring it home. I mean, our population is 1.1 million. We've got about 72,000 people who are out there partying, using, then they become dependent, and they're in the queue. 20,000 people who, if they get arrested, probably are eligible for drug court. And we don't have enough treatment beds. We need to incubate treatment facilities. I have our friends here from CATS, Community Assessment Treatment Services. It's easy to remember, CATS, they're on Broadway, CATS on Broadway. Roxanne Wallace is here, she's the Executive Director of CATS, and John Scalish. And we've worked with CATS. The Adams Board contract is with CATS. The majority of people getting treatment in drug court go through CATS. Here's what you really need to understand about what we're doing wrong. And this is just something for the committee to know. This is not something the committee can change. Dependency is a chronic disease. What's a chronic disease? A chronic disease is something that if left untreated, it will kill you. Diabetes is a chronic disease. Hypertension is a chronic disease. Heroin dependency is a chronic disease. Alcoholism is a chronic disease. So if I'm hypertensive, my blood pressure is 190 over 140, and I show up at the door of Hillcrest Hospital, what's going to happen? They're going to take my insurance card, they're going to admit me, they're going to medicate me until my blood pressure comes down. I'm going to have medication for the rest of my life to help control that. I'll certainly have to take responsibility and eat better and take other steps to benefit my personal health. My insurance will probably cover the majority of my care. Now, if I was heroin dependent and I showed up at Hillcrest Hospital, here's what would happen. Wouldn't care about insurance because they don't have a detox facility. Hardly any hospitals have detox facilities. They would say, okay, St. Vincent's, Rosary Hall, has a detox facility. And if I was lucky enough to make it down there without using it again, I'd get to St. Vincent's and they'd tell me it's at least a 2-week wait. You know, call us every day. And there's very little chance that somebody heroin dependent would be able to make it 2 weeks without relapsing. But if I did make it 2 weeks, you know, I'd go in, I'd detox, and my insurance might pay for a 30-day Glen Bay type program, an intensive outpatient, which is you get about 10 hours, 11 hours a week of programming, but you're in a residential facility. In drug court's experience, we found 30-day programs just aren't sufficient. And I'd probably relapse at some point and have less opportunities for success. If I did make it through a program and maybe I went to a sober house, I'd go to a sober house. Most sober houses won't allow you to be on medication-assisted treatment in the form of Suboxone. Suboxone is like portable methadone. It's a film, you take it daily. It is not a complete blocker. It lets you function, lets you hold a job. But most sober houses don't want that kind of medication in their facility. I could take Vivitrol. Vivitrol now it's a 30-day, very expensive, complete blocker that helps with their cravings. Medicaid now pays for Vivitrol because it's about anywhere from $600 to $1,200 a shot. It is a complete blocker, and we're starting to have some of our drug court people use Vivitrol. So we have a problem with medical parity and how we treat chronic diseases in this country. I mean, I would be surprised, frankly, if there was one person in this room that didn't have, you know, what I call an Uncle Billy in their family, somebody who was an alcoholic or somebody who had some substance abuse issue. Dependency is a great believer in diversity. All walks of life, all socioeconomic groups suffer from it. And we just, as a society, choose to treat it over here and not at the Cleveland Clinic with world-class healthcare. And that really needs to change because think about how expensive this disease is versus the cure. When people finish drug court and they return to their communities as employees, they pay taxes, they hold jobs. Parents, their kids are much likely to need care from the system and much less likely to end up in the system. And just normal people. When they're dependent in full usage, they're breaking into cars, they're breaking into houses, they're stealing checks, they're not working, they're in the criminal justice system, they're getting assigned counsel. You know, it's much more expensive to not treat the disease. So I was a finance major at Miami University. I thought I'd be working at Harris Trust in Chicago after graduation. Now I run drug court. I'm pretty much completely self-taught. I do not feel comfortable ever playing doctor, but basically I'm the doctor a lot of times in drug court. So let me go through drug. Do you have any questions at this point? Have I glazed everybody's eyes over at this?
We can break it up if that works.
I mean, feel free to
In your
interrupt me
presentation.
if I'm, I want you to get as much out of this as possible.
Let's start, Councilwoman Brown.
Thank you. The first thing that I wanted to address, which was just a few seconds ago, you said 30-day programs are not sufficient.
For heroin, opiate-dependent individuals.
What is a sufficient length of time? What have you found to be a sufficient length of time?
Well, what seems to work best, our folks go through 90 days, typically at CATS, sometimes at other places, of IOP, intensive outpatient. So they live there. They've taken out of their old using environment, and triggers, people, places, and things are a very big part in avoiding relapse. So you come into a sober house or a sober hospital. We can't really call them hospitals. They're treatment facilities. They don't have doctors there. They don't have nurses. They have caring people who are chemical dependency counselors. So 90 days, they live there. They receive 10, 12 hours a week of therapy.
Yeah, it turns out to be a bit more, but it is much below the Cadillac standard of 30 hours per week of non-medical community residential.
So you discharge after 90 days. What we require in drug court is that before you're allowed to be discharged, you have to go through Project Dawn and get yourself a overdose prevention kit, a naloxone kit. It's not a license to use. It's like a fire smoke alarm. It's not a license to smoke in bed, but if you have a fire, you're going to be certainly glad that you have a warning or a fire extinguisher to help save you. So after 90 days, where you go varies. Some people go home. We prefer that. We can't make you go because we don't have the funds and the beds for everybody to go to a sober 3/4 or halfway house. A 3/4 or halfway house is basically a home in any neighborhood where there's 8 to 10 either males or females living. 80% are pretty serious about the sobriety, and they all help each other. So halfway house time is important for people who don't have any place to go back to that doesn't have triggers. I've talked to people, they move back home, and before they do so, their parents got all new furniture, painted the walls, changed the carpet, got rid of all the triggers that existed in the kid's bedroom. The nightstand, that's where I used to cut my heroin up. You sit down, you look at that, what do you think of? Using. So you have to remove all this stuff. The key about sober house is it just is a safe environment that allows you to continue with your recovery. The brain, have any of you seen the functional MRI images of a dependent brain? I mean, you have physical changes in the brain when you're in the height of your dependency. And then you see, there are studies that show 6 months into recovery, 1 year into recovery, and you show a marked change. I mean, the brain never fully recovers, but it recovers enough that you can go on and live a very productive life. So you need to sit basically and learn about your disease and work on your habits. Dependency is like any other Pavlovian-based disease. If you're overweight, you're used to eating at night while you watch TV. Think about how hard it is for us to go to the gym and develop that exercise habit. Regaining sobriety is as difficult. How hard is it to quit smoking? It's difficult. And it's difficult to, your brain, this is clearly a brain disease. I mean, make no mistake about it. 2/3 of my judicial colleagues around the state feel it's a brain disease. I have a third who don't. They think it's a lifestyle choice. So, number one, as a society, we have to recognize that this is a disease and it should be treated medically like other chronic diseases. So, to answer your question, 90 days, intensive outpatient with a residential component at a treatment facility, followed by, months in a sober house as you gradually transition back to what we would call a normal life.
Thank you, Judge. The other question I had with regards to that is, as you classify this as a disease, and I think that that's something that I certainly would agree with. However, I feel like the medical emphasis of drug addiction did not occur until it hit the Caucasian community hard with heroin addiction, and you have identified your court as a white court. So is this an insurance issue? Is this a hospital issue to identify it and treat it as such as a disease? Where does the course of correction lie?
Well, the court, I don't have any say in who comes into drug court. We set up drug court to, we cast a wide net. If you have 3 or fewer prior felonies, you're eligible for drug court. If your crime is a 5th-degree felony, 4th-degree felony, or 3rd-degree felony, we'll take you. We don't take 1st or 2nd-degree felonies. We don't take people with a history or an indicia of trafficking. And because we don't want to introduce, put the fox in the hen house or introduce a drug trafficker to a whole new bunch of clients. And we don't take sex offenders. So other than that, 3 approved prior felonies, an unlimited number of misdemeanors. Your prior criminal record generally isn't a bar to getting in drug court unless you've got a trafficking conviction. So, and the referral source is either from the defense attorney through, cases get assigned in the arraignment room to my 33 other colleagues, most of whom are pretty good about referring cases to drug court when they know what to look for. Sometimes defense attorneys take the initiative and ask for the case to be transferred to drug court. The judge who has the case doesn't have to transfer it, but we've shown that we do very well with folks who come through drug court. Historically, our biggest source of referrals has been the county prosecutor's office. The county prosecutor, both under Bill Mason, who was county prosecutor when we started drug court, and Tim McGinney, have been excellent partners in referring people to drug court and supporting drug court. So we're proud of that. Now, I brought a report card that I want to go over to just show you drug court success. And let me fast forward in the presentation here. I'll go back. The first 249 people who came through drug court were followed by case, and I think 56% of those graduated. So Case did a follow-up study, and they also created a control group of other people coming through common police court who didn't get drug court. And the last column is a significant column. This is 12 months after they either graduated from drug court or failed out of drug court. We measure success on rearrest. Are you coming back into the system? That's our goal. Right? I joke, what's the difference between drug court and Denny's? Only one of us wants repeat customers. So we're pretty good at getting people to not come back. So if you look at the last column there, out of 249 people, 27% in the control group, 27% were rearrested within 12 months after being done with court, compared to 8.4% for all the drug court participants, not just the graduates, it's all the participants. Only 4% of those arrests were for felonies. So, if you know a little bit about what the state pays for percentage points and reduction on recidivism, states generally pay millions of dollars to try and bring down recidivism 4%. We brought it from 27 to 8.4%. We should have a 3-year study out soon. Case folks are working on that. We assume the numbers will be higher as a result of more time passing. But what 8.4%, what's great about that number is that's not just the graduates. So people, we have what we call successful failures. People that go through treatment, we make them go to 12-step meetings. They learn about their disease. You're required to have a sponsor. It's a comprehensive approach to recovery. They get the tools that they need to stay sober. They may fall off the wagon 6 times when we finally kick them out, but they eventually learn how to live. Just having the dosage of drug court, as shown by these statistics, goes a long way. So what I haven't told you about is really, okay, what did I do wrong here? Sure,
Judge, maybe I can ask a question while.
you can.
You just showed how successful the recidivism, how you have been able to reduce recidivism. It's interesting that you also said that those in the drug court are predominantly Caucasian.
Right, the statistic, I think 76% were Caucasian in this study.
Okay, predominantly Caucasian. And you explained how that the insurance, and I pretty much followed the rationale of how that has happened, and I can accept that. Let me ask one question though: is there a need for drug court in the African American community?
Absolutely, absolutely.
So
We have a partner court in Cleveland. Well, Cleveland Muni Court has a drug court, and I don't have their numbers, but I think their ratio is the exact opposite for African American versus Caucasian. They have a jurisdiction that's just Cleveland, and Cleveland, the population is 50-50, and they get the misdemeanors. Crack pipe cases aren't coming to our court anymore. So your regular pulled over marijuana cases end up there. I would imagine we need to serve the African American community. Absolutely. We have been asking this question for the last 4 or 5 years since we got up and running. Why does this court look different than the rest of the building? And, medical parity, crack pipe arrest policy, that's the best answer I can give you.
it's a different arena, but we spend a lot of time certainly discussing the segregation of dollars and how, whether it's in contracting, whether it was the 3 major sports teams back in the 80s. So
Do we have professional sports teams in this town?
I think we still have.
Okay. I know we have at least one, but I'm not sure about the other 2, but.
So I always like to get to the heart of, well, how can we know what's happened? How do we start to address it? Are there any strategies? I heard you say we've talked about it quite a bit. Are there any strategies of how we start to meet the needs of the African American community in that respect?
We need to promote recovery. When somebody overcomes cancer, what do? We celebrate it. It's great. Betty beat cancer. Alcoholics Anonymous is Alcoholics Anonymous. We don't want him to know that he's in the program. That shouldn't be. I think we would be much better served if we destigmatized this disease. Making people unafraid to go get help. I've been to countless AA meetings, and you see, the pillars of the community that go to AA. If the community saw the pillars of the community that went to AA, they'd be, it would go a long way to destigmatize the disease. And when you destigmatize disease, more people are willing to come forward and get help. Vice President Jones, I don't have any great answers as I stand here today as to how to get more help for the African American community other than, building medically supported treatment facilities that serve everyone regardless of insurance care. And I don't know who's, leads the charge on that, whether it's the federal government, the state government, county, the county. We know, on one hand, I would be upset. The African-American community should be upset that this kind of approach wasn't taken during the crack epidemic of the 80s. On the other hand, be thankful that the African-American community hasn't been hit by the heroin epidemic because it is so deadly. It's a disease of tolerance. Why do people die so much from this? Because say you get arrested or you leave drug court, you've been sober involuntarily for 90 days. You go out and you use the same batch you used when you got in, your tolerance is way down here now. And you arrest. Your breathing stops and you die. Now we have fentanyl, which is the newest scourge. And you would wonder why anybody in their right mind would want fentanyl. But fentanyl is 20 to 40 times more powerful than heroin. What happens is, after a time, most people who use heroin aren't using it to get high anymore. They're using it just so they don't get sick. When you stop using opiates or heroin, you go through withdrawal. And I brought you this article about this lawyer in Columbus. It talks about how she had surgery, she started getting hooked on the Percocet, and she started sweating every 3 hours after she used the pill. She was going into early withdrawal signs. So the disease hooks you like that. So you might need, 2 Percocets the first week, then you need 3 the next week, then, 4 months down the road, the doctor thinks, okay, you got a problem, they're cutting you off, and you're on the street using heroin because it's 10% of the cost of Percocet, and it's a lot easier to get. When I was on the medical examiners committee, we learned a lot about doctor shopping. About 35% of the overdose deaths involve people who were doctor shopping within the 12 months prior to their demise. Doctor shopping is defined as getting a Schedule II drug from 5 or more different physicians in the prior 12 months. Now, these folks were doctor shopping, not necessarily to use the opiates that they'd get a prescription for. They'd get a prescription for Oxy, and they would sell it, they'd arbitrage it, and then they'd take the money and they could buy 10 times the amount of heroin. So we've learned all kinds of interesting connections about this. We need to treat more people, but we can't treat more people because we don't have the facilities. We need more. We need to do whatever we can to incubate more treatment facilities. CATS is the biggest game in town. I'm sure you've heard of Stella Maris, or over at the bridge on the other side. They have a fraction of the beds. They do have a detox facility. Most people detox in this county in the county jail. That is the biggest detox facility, and it's not nearly as therapeutic as St. Vincent's is. I failed completely to tell you how drug court works. We have a team approach. We have a prosecutor, we have a public defender, we have a task case manager, pretrial services officers, and what Judge Sinenberg's doing right now in a jury room, is meeting with the team. And we meet with everybody in drug court at least once a month. Some people we see twice a month, but everybody in drug court has to come through and meet with the judge at least monthly. So prior to their meeting, you sit down, and 2/3 of the people are in compliance. We call them, they're on the honor docket or in the honor box. We put them in the jury box when they come to court. They can sit there, kind of like a little incentive. And then we have others who are not in compliance. Either they've been capious from treatment or drug court, or they've relapsed and they're your analysis has betrayed their drug use, or they've at least admitted to it. We prefer they admit to it. Or they don't have an excuse. They haven't gone to their 3 12-step meetings a week. So we sit down and we talk as a team, what's going on with that person? What's our response to their behavior going to be? And we use the science. Now, somebody relapses 3 months into drug court. We're not going to throw them in jail as a sanction. We use a system of distal and proximal goals. So if somebody relapses, we know relapse is a normal part of the disease process. We're not going to throw them in jail. If they're honest with us, if they tell us about it and they're willing to continue to work, we'll redirect them to more treatment. Maybe they have got to change their living environment. We'll work on that. Somebody 3 months into drug court doesn't go to their AA meetings, that's an easy goal. That's a proximal goal, not a distal goal. So you're going to get 2 days in jail for missing meetings. And the science from the National Association of Drug Court Professionals shows that that's the most effective way to treat people. So we use a multi-faceted, non-adversarial team approach. As I indicated, we both have the prosecutor representative, Brian Murphy, and our drug court public defender, Bill Kelly, are there. Both, are offering suggestions to help this person. It is complete opposite of the traditional adversarial system, the pretrial system that most people recognize in the criminal justice system. It's almost a clinical approach. So I brought also in the packets, multiple packets, actually, I'm not sure if I brought this one. State Representative Sprague has been instrumental in drafting legislation to combat this crisis, and their team has found that some behavioral health care providers had a 10% recovery success rate, others had almost a 60% success rate. The higher success rates come from providers that have integrated systems of care, which includes some or all of the following: an ambulatory or subacute detoxification, non-intensive and intensive outpatient services, medication-assisted treatment, peer monitoring sponsors, residential treatment services, 12-step approaches, and I think most importantly, recovery housing. We utilize most, if not all, of those things on each individual patient coming through drug court. It's expensive, but it's worth it. CATS charges us, about $1,700, $1,800 a month per person for our 90-day intensive outpatient with the residential component treatment. So most people going through drug court, we're spending about $5,000, $6,000 on a treatment county pays for that. The state has provided us with some funding for medication-assisted treatment. We also got Sprague, Robert Sprague, to sponsor a bill. Each drug court docket gets 65% of a full-time task case manager. So we have 2 for each of our dockets. So
Could you go back again to the list of treatments?
what we use,
Yeah, you had a screen on that.
yeah,
Okay.
12-step program. It doesn't have to be AA. There are HA programs, there are CA programs. Some people we send to Sex Anonymous programs. We have people that have issues with that inhibits their recovery. You have to have a sponsor. We can't make you work the steps. I always ask, what step are you on? How's it going? We test you weekly. We have a Codaphone system. We had James come back last week before our graduation. We've graduated over 300 people from drug court in our over 6 years now. James came back just to say hi. It's always great when this happens. James caused a lot of trouble on the east side for many years. Wonderful guy, sober, not so much when he was using. James told me he still calls Codafone every morning, even though he's long since graduated from drug court, just to remind him of where he's at. So the Codafone program is you're assigned a color. If your color is blue and you call in, today's color is blue, you have 24 hours to submit a urine specimen for testing. MAT is medication-assisted treatment. It's complicated, but there are several different types. There are complete blockers, as I've explained, like Vivitrol, which is a 30-day injectable, long-acting injectable. Vivitrol is the injectable, long-acting version of naltrexone, which you take daily. It only works if you take it. So if you're early in your recovery and you get a case of the screw-its, you just stop taking a pill, and a couple days later you can use. And there's Suboxone, which is slightly different from buprenorphine, which I call the portable forms of methadone, and I'm sure everybody's heard of methadone. You get the clinic right here around the corner by King Nut, but you have to go there every day. What you need to know about medication-assisted treatment: all studies have shown that people who use MAT have better outcomes than those who don't. It doesn't matter whether it's methadone or the new kid on the block, Vivitrol. You're going to do better longer term if you're using medication-assisted treatment. So, that's an important part of the recovery process. What you should not believe, though, there's no magic bullet. Vivitrol, without working the steps, without having a sponsor, without going to group meetings, without getting treatment, isn't going to do it for you. There's no magic pill you're gonna take and lose 30 pounds, and there's no magic shot that's gonna keep you clean. So I'm very fortunate to be able to work in drug court. It's changed the way I look at our criminal justice system. I think it's the way to go, the team approach on most aspects of it. One of the philosophies I live by, and I borrowed from somebody else, is we send the people to prison that we're scared of, not that we're mad at. And, that stubborn guy in drug court who keeps relapsing, and, he's somebody we're mad at. So, we balance that with the needs of protecting the community. We know, untreated, that they're going to continue to commit, low-level felonies to feed their disease. I do want to humanize this a little bit. Oh, this is one of the best parts. Graduation packets. So before you graduate, you have to fill out an application to graduate. And we ask several questions, two of which are: describe your life before drug court. And this is a typical answer. My life had no real purpose. I was completely hopeless. Before drug court, I would pray every night that I would not wake up the next day. It was like a living nightmare. After drug court, my life has purpose today. I can be the mother to my kids they deserve. He's finally living life with a purpose. It really goes to the essence of what we are as humans here and why are we here on this planet. This is Tracy. This is Tracy coming into drug court. This is Tracy today. Tracy failed out of drug court. This picture was stolen from Tracy's Facebook page. Tracy got sent to Marysville, had a baby down there. As we do with many people who fail out of drug court, who sometimes we incarcerate them. When they get out, it's usually through judicial release. But when I send someone to prison out of drug court, it's only to help them finally find their bottom. And we've tried everything else to help them to find their bottom. And that's about the only thing the state penitentiary system is good for in drug court, is helping people find their bottom. So she got out. I put her on regular probation. 9 months later, I got a call from her probation officer. Hey, Tracy's doing great. Can we terminate her early? And I remembered Tracy. Tracy was very uncooperative in drug court and just really someone who I didn't think well of in the long term. So I'm like, okay, well, I want to see her first in court before we're going to terminate her. She comes in, she brings her mom, she brings her child. She's working 2 jobs. This was 5 years ago, and she's still clean and doing great. So she's one of the 44% who didn't graduate, and she's a mom. Her daughter's going to be raised and not going to be in the system. She's working a job, she's paying taxes, and she's a big success story. So this is also stolen from her Facebook page just to humanize, look at that quote. Mommy, I pet the puppy, I pet the kitties, I pet the duckies. Is that someone you visualize as that? No. So very lucky to be able to do what I do, and it's frustrating work, but it's also extremely fulfilling, and it's definitely the right model, and we need to expand it. Every judge in Ohio should have training in this regard. And I told you I was a finance major. Most people come to the judiciary from various paths. Hardly anybody comes with a chemical dependency background. So expanding mental health knowledge and drug dependency knowledge is very important. And unfortunately, we're treating a massive public health problem mainly under the criminal justice umbrella. And in an ideal world, we'd be doing it differently. But what really works in the justice system is we can hold people accountable. Parents can't do that with their kids when they're dependent. Husbands can't do that with their wives when they're dependent. You can check somebody into Glen Bay. If they don't want to stay, what's a mom, dad, or husband or wife to do? Somebody leaves cats, well, I've got my friends, the county sheriff, who goes out and gets them, and we redirect them. So,
Well, thank you, Judge.
Thank you very much for
the
your time.
presentation. The committee certainly has a few questions, so we want to open it up for that. As you were speaking, it made me think in my own experience as a funeral director, times when I've buried individuals who were victims sometimes of gun violence or other violence, where the individual perpetrator was in South Point Hospital or some hospital. A parent would come and say, my child doesn't need this mental health or some type of assistance, and they would check the person out, and then weeks later, they would commit some type of crime that would harm someone else, and you'd always trace it back to those moments. So it's a real problem, a real concern, and just wanted to share that. So let's open up to committee. Councilwoman Conwell.
Through the chair to the judge, just going on, I have about 3 questions, and they're related to your slides. Do the individuals who steal or break in cause is because of drug uses? Do they come to your court if they broke in, but the cause was because they were on drugs? Do they come to your court, or is that another direction?
Yes. In order to get into drug court, you have to go through a drug and alcohol assessment. Okay. I mean, you go through the record check to make sure you're record eligible, you're not a trafficker or have a history of violence, but you have to be dependent. We don't want to spend $5,000 to $6,000 in treatment on somebody who was just caught at a fraternity party with some cocaine, but who's not dependent. That would be a waste of money. So you have to go through an assessment to make sure that you do have a dependency issue. And there's a difference between drug abuse and drug and alcohol dependency.
Okay. Is drug court open to the public? You talked about.
Yes. Okay. It's all open to the public, except for team. But if members of county council ever want to come down and sit in on team, we would welcome that. I would urge you and your other members of council not here to come visit us someday. We have drug court. My docket runs basically almost every Thursday morning at 9:30, and we go to about noon. First part of drug court, we deal with folks in the honor box. I speak to each one of them, ask them how they're doing. We use motivational interviewing techniques, which we've learned. A lot of open-ended questions. And, you can tell whether somebody wants to talk about their new job, their new car, or how they're doing in the program, We direct them to tell me about how you're doing with your sobriety. I don't want to hear about your new Jeep or the new job, although I'm glad that you're working. So we talk to everybody, and then we have our non-compliance docket. And then the new people coming into the program at the end plead in, and we explain a little bit about, what they're going to go through. We want to make sure that they want to do drug court, because drug court's a lot harder than regular probation, but we do a lot better with recidivism.
Does drug court do anything on the side of prevention?
We do. At least I do. I've been involved in a lot of different efforts. What I did is we spearheaded the expansion of a drug drop box program throughout the county. Under the Fitzgerald administration, we got the county executive to agree to, I think we bought about 44 boxes. And we collaborated with the sheriff's department. The sheriff department agreed to go around and collect what was dropped off in the drug drop boxes. The hardest part was finding an EPA-approved facility to get rid of the collected drugs. So I didn't go over the most important chart there. The red chart with the line, that's it. That is everything you need to know as to why we're up to our eyeballs in heroin deaths. There is almost a perfect one-to-one correlation between the dosages of opioids written in society and the death rate from overdose. You want to bring the death rate down? You get doctors to prescribe less. So I thought of the drug drop box program, expand it, because we know the medicine cabinets of America are full of opiates. You go get your wisdom teeth out, you get 25 hydrocodone. What do? You might take 3, and the rest are in your medicine cabinet until your kid's friend comes over and diverts them and takes them to their party in Bay Village, and then they're off and running. So we thought we could make the community safer by trying to take some of this excess unused medication out of the medicine cabinets of Cuyahoga County before it gets diverted. So that's one mild prevention program. Any effort county council can have and assist us in publicizing these boxes would be welcome. It's an easy plug and play program. You just go to rxdrugdropbox.org and you type in your zip code and you get a Google map of all the boxes nearest you. All 5 districts in Cleveland have a box. Virtually every suburb has a box with a few exceptions. And to date, we've collected in 2.5 years about 27,500 pounds of medication. Now the feds still do their twice a year drug take-back days, and I got the idea to expand the box when I learned on a mildly publicized event on a Saturday, over 4 hours, they would collect 4,000 to 5,000 pounds of medication in this county. Oh, there's a lot out there. There's still a lot that we don't get, and we need to do a better job publicizing these boxes. The U.S. Attorney's Office has done a nice job in organizing speakers to go around and talk to kids, but dependency, if you go to any AA meeting, you learn quickly, all the leads are kind of the same. I was escaping from something. I was escaping from trauma. I was escaping from, I didn't feel comfortable at parties unless I drank, and then the upperclassmen found me funny, and I was born with those genes where, I didn't have the governor. So it's a disease of escape, and if you can explain to people that there are healthier ways to treat those things. We get people more treatment for trauma. They don't turn to other forms of escape. We're always going to have this disease, but we need to do a better job of society of recognizing it, of destigmatizing it, and providing medically appropriate and medical parity for its treatment.
Well, there certainly is a stigma. It makes me think of, I talked with Bill Dennehan, and when I first took office, and he educated me on the entire world, or gave me 101, and he described it: primary care and behavioral health, mental health care. If you're playing baseball and you break your leg, you go to Cleveland Clinic, give you primary care. Well, was that your fault? Yes, you slid into second base and you broke your leg, but they took care of it. There's no stigma. You are equally responsible for what you've done that caused the damage to your brain, not your ankle, and but you still need help. But there's a stigma attached. So that's certainly something.
We need to be, right, back to the diabetes. You overate and you became diabetic. Do we blame you for that and stigmatize the person who was born with the genes that, the drinking led to a dependency? It's treated differently. It's looked at differently by society. Smoking. You're smoking, you got lung cancer. Do we stigmatize those folks? Not really. We're happy when you beat it. The difference is when you have diabetes, you don't break into cars and steal stuff. You don't break into houses. And because of the lack of treatment, people are forced to do things that do put themselves in the corner. So, it's
One question, as far as the giving back of the drugs, how much effort has been placed into when the pharmaceuticals or when the doctors prescribe, instead of giving a whole bottle of excess pills, why not give smaller amounts of
well,
pills?
you've just opened the Pandora box here. Okay, I thought I was going to go home, but this is going to be another half an hour. We have perverse incentives in the medical profession to overtreat pain now. I don't know if this committee's ever dealt with the subject of HCAP scores, but HCAP scores are data in which the government decides how much reimbursement we're going to give to the hospital for the care. If a doctor's individual HCAP scores on the subject of pain aren't perfect, the administration comes down on them and says, hey, your HCAP scores are bad, we're not getting what we can get back when the federal government reimburses us for Medicaid or Medicare reimbursal. So these are questionnaires you see, patient questionnaires at the end. How well did we treat your pain? So the medical profession and the CMS, the Center for Medicaid Services, is responsible for these HCAP questions, and they don't have any interest in changing them. So they provide a perverse incentive to overtreat pain. I started this talk out with the Joint Commission, JCO's decision to make pain a vital sign. I think that needs to be revisited. It is not realistic for the medical profession to expect people to be completely free of pain. If you look at one thing of the materials brought here, read the Columbus Dispatch story on the lawyer. Her story is typical. When I started drug court, I'd take surveys of the opiate-dependent people. Half the people in drug court originally started treating for a legitimate medical condition and got hooked on the medication, and then turned to street heroin. The other half, they call it their fun meter hit the red. They started partying, and I don't know, things progressed that way. But I had this was before drug court. I had somebody on a nurse from the Cleveland Clinic on a theft case. She was charged with stealing pills from her hospital. And I'm looking at her and go, how did you end up, your 44-year-old married mother of two, in felony court? She had brain cancer. She treated successfully for it. Brain cancer went away. She got hooked on the pills. And then when she went back to work, there's a stigma. She didn't tell anybody that she was dependent, just like that lawyer. The lawyer in the article actually recognized that she was having a problem and self-arrested, which is kind of amazing. Most people, they don't have a chance, and, you know, they turn to deceptive acts, thievery, and what else? They're just answering their body's call to use. It is the science, it's a Pavlovian pathway that is worn into the brain, and it takes a while to reverse that. So,
Judge, we have a few other questions. Councilman?
Thank you, Chairman. Your Honor, just because obviously this affects all of us in a gut-wrenching way, is there a map that actually shows a plot map of Cuyahoga County where your cases are coming from that would be available, so that would actually bring this clarity to all of our constituents throughout the county? Because I think there's some that think that, oh, maybe it's over here, or it's over there, or it's in Bay Village, or wherever it happens to be. But do you have a dot map that would actually show?
I don't have a dot map. The medical examiner's materials have the best breakdown I've seen as to, and they might have on their website by zip code. I'm sorry, I just about lost my voice completely here. I would turn to Hugh Shannon. He's the information guru in that office, and he can get you death rate by zip code. They keep track of the zip code where the person died at and where they were residing when they died. So there's two different maps that they'll show. You know, they can show how many people died in Lakewood, how many people died in, you know, I think they break it down by the not by ward in Cleveland, but by police district. So they do have that.
But that's the death. I'm looking for, once they've got to your court, it's a public piece of information, I assume, is it not? The trial and the court and everything about it and the box that they're in, so that's not a private piece of information at that point in time. It's public, and I'm not looking for their names. I'm just looking to take your same photograph that you have of either the football stadium or and actually plot that entire
My drug court population, where they live.
where they live, where they're coming from, so that we could actually tell the world that, hey, this is what, 60,000 people that are, if we're using the stadium over there, or I don't know what, 25,000 over at the Q, that we could actually show that map and say this is where, because it takes it the next step. It takes those Q people, instead of just being a photograph of the Q, it actually says, hey, this one is living in Bay Village, and this one lives in Chagrin Falls, and this one lives in, and not by name, obviously, but by the mere fact that you've taken that photograph and related it now back to this county.
Yeah, I don't have anything like that. I can tell you
We have the records. You just
With the Adams Board?
I don't know where it would be, but it certainly would. Every time you can move it from the theoretical down to the individual, it just brings it I think that much more of a solution that the people can buy into why they should be participating and trying to get to the solution. Whether it's the mayor of these communities or whether it's the city council, because I know that the other thing I'd like to have is this Dropbox map of the county, so that when I'm talking to my constituents, I can say, boom, here's the map. Here's what it is. Because I know that the same as you said,
yeah,
everybody has a medicine
your
cabinet
district-
full of stuff.
Your district, I can tell, is a lot better off than Mr. Miller's district. I live in Cleveland Heights. My kids go to the high school there, and in some ways, I'm very happy that they're there and not in Bay Village or Westlake or right over the border in Avon Lake. The West Shore suburbs, Lakewood all the way west, are awash in heroin. The east side, not as bad. It's sold a lot in Euclid. But I don't have a picture graph for you. And I would be hesitant to put any of, even though it's a public record, I would not be interested in putting the pictures of the people I have in drug court up for public.
No, I wasn't trying to insinuate. I'm trying to suggest that
And these people
That-
are transitory. They live everywhere. They couch surf, so it's kind of hard, you know. Many people in drug court are living at 70th and Broadway right now at Katz. You know, where they got arrested is different, but it's, I'm sorry, I don't feel like I'm answering your question, but.
No, I wasn't looking for their name, their picture or that. I'm just looking for, this file came from Bay Village. And so if we could identify where those files came from without necessarily the name or the address, anything other than, because what it means is when you're sitting down talking to that mayor or that council, you say that, hey, here it is, right here, folks. 25% of these are sitting right in your district, and you might not even realize it's going on. That's, is that clear?
I think most public officials know what's,
I bet you they have the same reaction
Independents
as
know,
as your lawyer does in here until they came to grips with, that the problem is real. It's in their community. Because I'd be willing to bet that they too ignore it until it comes home and it's your next door neighbor, your friend, or your, that we're seeing in this.
well, we all think it's somebody else's problem
course,
until it
yeah.
enters our house, yeah.
Yeah, and so all I'm trying to do is bring it home to the communities that where this is resident, and it's not your neighbor's problem, it's not somebody else's problem, it's not Purnell's district, it's not Dale's district, it's every one of our districts, and we just need to bring home as to how it is. And you've got, you show a picture of the stadium, you show a picture of, I just want to say that 5% of these people in this stadium picture are coming from our we got 59 communities.
Yeah, it would be hard to break it down accurately on that lines.
Well, I can only assume there's an address in that file that says that this is a location within Cuyahoga County, but if not, we are having a state discussion on legalization of marijuana. Where do you have a point of view as to whether this is a transitional type item that's going to get us closer to where you are, and what if opinion, if any, do you have?
I
about
watched
the
with
current-
puzzled amusement at the discussion on medical marijuana that appears to be the last ditch chance of the proponents of marijuana to get some kind of legalization in Ohio. There is no medical marijuana. There's no science out there where marijuana has been tested and shown to be a adequate form of medical treatment for glaucoma or whatever disease you want to name. It's not there. So this is just a fraud to get marijuana into the fabric of society. Should we be incarcerating people who smoke? No. Is marijuana, as big a problem as heroin? No, not even close. Is it a gateway drug? Kinda. Lack of education, poverty, childhood abuse, those are gateway drugs. Those are what make people use. Alcohol and marijuana are somewhat similar in harm, propensity. The worst thing about marijuana is most people smoke it, and it's bad for your lungs. It does destroy your drive if you smoke it often. But if you're a 50-year-old guy who drinks twice a week, and you change and you get high twice a week, your brain's fully developed at that point. It's going to have some health effects on you, but it's not an opiate or heroin or cocaine that do their destruction a lot faster. I'm not meaning to minimize marijuana. I'm not advocating it should be legal. But, it's the topic of the day. And look at those medical examiner statistics. Nobody overdosed and died smoking pot. People overdosed and died on a lot of other stuff, fentanyl, heroin, cocaine. So, you know, it's kind of a non-issue. The monopoly that was proposed probably didn't do a lot to get people to vote for the issue that just failed. I am kind of perplexed why this issue isn't dead in Ohio at this point, though, after the resounding defeat of that. Why are members of the General Assembly talking about it, and under medical marijuana has me scratching my head?
Your voice was so clear there. I hope people listen to it or hear your voice, because that's about the clearest discussion I've heard of why even have this discussion. So I encourage you to make that be known out there.
I'm much more interested in designing a healthcare system where, you know, if you're dependent on alcohol, heroin, marijuana, you can get yourself treatment. Yeah, right.
Yeah.
So,
Thank you for coming here today.
thank you.
Yes. Cocaine was thrown in there as well.
Yeah, I said, thank you.
Mr. Chairman,
Councilman?
I have a question before you run off.
Justice Thomas has a question, okay.
Earlier, you went through the complete package program, treatment and education, 12-step sponsorship, testing, sober housing, sanctions, monthly judicial visit, medical assisted treatment, etc. My question is, are there programs outside of the justice system in the mental health treatment community in Greater Cleveland that also provide the complete package of treatment?
We have 5 judges who are mental health court docket judges, and there are programs, and I'm not well educated into the intricacies of those programs. So perhaps you would like to invite, you know, Judge McClellan or Judge Villanueva down here. I can't answer your question, I'm sorry.
Could you say a little bit about the relationship between the drug court and the mental health court and what determines who goes into what program?
Well, mental health court take people who have a pretty serious mental illness, not being bipolar, but like an active psychosis. So schizophrenic or a developmental disability with an IQ level of 75 or below. So that's the target for the court's mental health program. We have, individuals in drug court who, have a mental health component to them, and that was one of the reasons we expanded Judge Sonnenberg's docket. Her docket is designed to treat people with trauma and mental illness. We found, why isn't this person doing well in drug court? And you peel back enough layers of the onion, and you find out that there was some kind of trauma there, some kind of abuse that was left untreated, and that's what they're still escaping from. So once you identify that they suffer from a mental illness and they have a drug dependency, you treat both. Many times, though, the symptoms of the mental illness decrease markedly, when the person becomes sober. I mean, you suffer from depression. What do you think alcohol does to it? It's a depressant. Marijuana, depressant. Heroin, it's a depressant. It makes your depression worse. So you get clean, and sometimes the symptoms of the mental health condition alleviate on their own.
Okay, thank you.
Well, we had a lot of questions, and you've been up there quite quite a time.
And my
No.
staff
go
attorney
right
has my
ahead.
phone. Is it like 3 o'clock now? I have no idea.
Councilwoman, go right ahead.
Okay, I'm sorry. Thank you. Thank you again for the presentation. I really appreciate the information that you shared. You pointed out that there were 5 signs during a joint conversation, the vital sign with the 5th sign being pain. Do you recall?
Pain is the 5th vital sign.
What were the first 4? Do you know? No.
See,
Okay.
that's why I went to law school.
Okay. And the other question I had is, you said that in order to qualify for the drug court, there has to be a determination of dependency versus abuse. Can you share with us the differences?
Well, that is done by a counselor with a chemical dependency license. We don't want to leave that up to somebody untrained to make that determination. So we have TASC, Treatment Alternatives to Street Crime. Are you familiar with TASC? It's under the Correction Planning Board now in the court. It used to be under the Department of Justice Affairs. And the TASC assessors, they're trained to do a drug and alcohol assessment that determines whether and they give a diagnosis. So, a lot of times you get, cannabis dependency and remission or, opiate dependency. So I'm not trained in how they do it. We get the reports, we look at them, it tells a little bit about their background too. They're helpful in sizing a person up as they come into drug court. But as far as the questions they ask to determine whether someone's just partying a little too much or really can't stop, I couldn't tell you the exact science behind it in the questions.
Well, I've learned quite a bit today from your presentation, so I thank you for that. A few things that, I guess, closing thoughts. You've really impressed on me the fact that when you just brought up the fact that the court is predominantly Caucasian. We provide services based on need here at the county. That's at least a driving philosophy. And sometimes that can be a contentious conversation just around need. But to me, it's not like dividing a pot of gold between 2 parties. It's trying to decide how to help 2 separate people. My goal is to help both. All that we are helping in diversion court now, we need to continue to help, and I'm sure there's more help we need to provide. But also, if there's a group, African American community and other minorities, females that are not being assisted, what can we do? And it's not an inquisition for you.
No,
it's a
this is,
presentation.
I'm completely comfortable talking to you about this. And here's where we walk a fine line. As a society, we treat this in the criminal justice system, and it's not the right place to treat. We do a very good job of what we've given, but, we have, in the news, we've got the Black Lives Matter movement. We have our Greater Cleveland congregation who's now, going around claiming that, Cuyahoga County is a felony factory. We changed the policy years ago on the crack pipes. So we're not sucking people into the criminal justice system, giving them a record. Then they have the collateral sanctions of being strapped with difficulty in finding employment. We're not arresting the people that we could help in drug court, but do we really want to, how do we walk the line and straddle the line so we're not sucking people unnecessarily into the criminal justice system to help them with their drug addiction? On the other hand, they end up with a stigma because, you cast a net, 100 of the fish that you catch, only 10 of them are going to end up in drug court. There's only so many resources. The rest are going to just be untreated in the criminal justice system with a record. So there's no easy answer. We've looked around for this forever. When we think, we don't go out and cherry pick our people. That would throw off the integrity of our results. Our indictments used to be at 18,000, 20,000 people indicted in this county a year. This year we're about 10,000. They're down markedly. So many fewer cases are coming to the criminal justice system. And,
Well,
we can't tell from where we sit whether, you know, we know crime is down, but are police arresting fewer people too? You know, so we know it's a problem. And, I wish I could give you some better
Well, Judge, and I'm not
assertion
asking
that.
for an answer right now, and I understand you certainly are not cherry picking, but the segregation has happened nonetheless. Where it originates, I don't know. My thought would be, would you know if there was my thinking is a round table of individuals who have the solutions, who have the capacity to deal with the solutions? What would you envision as the right people in a room to have this conversation? Is that county leadership, city of Cleveland leadership, certain, how would you just in a brainstorming moment, how would you just picture a room where
First
some
of all,
of the
you have to-
answers would come out of?
What's your goal? Get more community representation in a drug court, or bigger picture, design a system that's, you know, not a drug court system where people can get help that they need when they need it, free of charge, or, you know, where they're, you know, it doesn't matter what your economic abilities are, you're gonna get the help. You know, we could sit down and probably figure out how to get the percentage of African Americans in a drug court up. But that would be, you know, a drop in the, I mean, you got a Brown Stadium full of people who've abused opiates out there. It just gives you an idea how widespread drug experimentation is in the community. You know, that's not cocaine, that's not alcohol. We need a massive overhaul of how we deliver treatment for the disease of dependency. So back to who will you want in the room to talk about this issue? Certainly police who have their handle on the data of who gets arrested. Some ER specialists who sees who comes into the emergency room on Friday and Saturday nights for, you know, dependency related injuries. You know, people with your generally bigger picture views. It's a you know, it's a big problem, and it's not an easy solution. But, you know, we take little steps forward and we all learn a little bit more about how it's all interconnected. So, you know, a lot of this stuff is a result of, you know, poverty and lack of education from the start, too. I mean, that goes a long way. So.
Okay. Well, Judge Mattia, we appreciate it. Are there any other questions? If not, thank you very much.
Thank you. I'm going to put a time limit on this next time.
Is there any miscellaneous business? Chrissy, has anyone else signed in for public comment?
No, Mr. Chair.
No. All right, if nothing else holds our attention, our meeting is adjourned.